So this is a PowerPoint regarding thyroid cancer and the surgery to remove the thyroid. So some of the normal thyroid labs that we monitor to detect hypo or hyperthyroidism or if we suspect parathyroid disorders are T3, T4, and calcitonin. Iodine is actually contained within a thyroid hormone. The TSH is secreted from the anterior pituitary gland, and it controls the release of the thyroid hormone. Our thyroid controls cellular metabolic activity. T3 is more potent and rapid acting than T4, but these are both hormones that are necessary for normal cellular metabolic activity. And calcitonin is secreted in response to high plasma calcium levels and increases calcium deposits in the bone. So without it, you can have brittle bone disease. But if you have too high, or if you have too much calcium, then we also have problems like kidney stones and dysrhythmias. So we're going to be monitoring the TSH, the serum-free T4, T3 and T4, T3 resin uptake, thyroid antibodies, because you can actually develop antibodies against your own thyroid hormones. The patients who have cancer may have radioactive iodine uptake that actually is part of detecting if there are thyroid cells left in the body. They may need a fine needle biopsy of their thyroid. Also, a thyroid scan or CT scan. Ultrasound is also some way they can see thyroid tumors. And then serum thyroglobulin is actually taken after radical thyroidectomy to see if any thyroid cells remain in the body. So thyroid cancer is much less prevalent than other cancers, but it accounts for about 90% of all endocrine cancers. So there are 4 main types of thyroid cancer based on the type of cell from which they develop. So there are papillary cancers, and these are the most common. Follicular cancers are about 10% of all cases, and this would include Hürthle cell cancers. Medullary cancers are 5 to 10% of all cases and may be associated with pheochromocytoma, which is very curable when it's detected early, but also there are a lot of medications that can actually cause medullary thyroid cancer, so that's interesting to know. And then anaplastic cancers, 1 to 2% of all cases, so this is the most lethal. So just because the patient has thyroid cancer doesn't mean it's curable, because all of these different types of cancers can progress to metastatic disease. So risk factors could be familial predisposition, chronic goiters, so that is just an excessive growth of thyroid, and exposure to ionizing radiation, NIC irradiation, so that's somebody who's had like other cancers around the neck. Iodine deficiency can cause follicular cancer. Multiple endocrine malignancies can cause medullary cancer. And then history of subtotal thyroidectomy for malignancy with anaplastic cancer, meaning they did not get all of the thyroid tissue out. And there's also a possible diabetic link in women. So thyroidectomy is the treatment of choice for thyroid cancer. So a lobectomy is just one side. Modified might be the side plus the isthmus, and then a radical neck is everything may include some lymph nodes. So they possibly may need radioactive iodine to minimize metastasis. This will actually kill all cells that contain iodine in the body, and that is only our thyroid cells. So preoperative goals would be to reduce stress and anxiety, to avoid precipitation of thyroid storm. Preoperative education would be dietary guidance to meet the patient's metabolic needs, avoidance of caffeinated beverages and other stimulants, explanation of tests and procedures, and head and neck support to be used after surgery. Postoperatively, it's extremely important to remember potential airway impairment. This is a surgery that's in your neck area. It's very near your trachea and esophagus, so there's high potentials of hematomas and the airway being compromised. So we're going to monitor for potential bleeding and hematoma formation. We're going to check the dressing. We'll assess for pain and provide pain relief. The patient's going to be in a semi-Fowler's position, and we need to support their head and neck. They're not going to be wanting to be in a non-neutral head position because it's painful. We're going to be assessing voice. We actually want to discourage talking because the thyroid is very near the vocal cords, and actually the nerves to the vocal cords can be in and around your thyroid. So we want the inflammation to die down, so we want the patient to not talk. We need to assess their voice for any voice changes and ask the family members and the patient if their voice sounds different. There is a potential hypocalcemia related to injury or removal of the parathyroid glands. There are 4 parathyroid glands embedded into the thyroid. They try to preserve those during that surgery. So basically, your parathyroid goes into shock, and we have hypocalcemia as a result of that shock. Sometimes it gets better, and they have normal calcium levels again, but sometimes they never return back to normal. So we're going to encourage the patient and family to verbalize feelings and fears related to the diagnosis and proposed treatment. We want to make sure they have clear explanations and answer any questions, assist with positive coping strategies, assist the patient in developing a positive self-image, and make sure we prevent deep vein thromboses because they might be kind of tired and not moving so much after surgery. And we want to keep them in that semi-Fowler's position with neck support, maintain that neck in a neutral position, and support the head and neck with pillows. Encourage the patient to avoid overflexion and overextension of the neck, and maintain that patent airway. We keep a tracheostomy set and oxygen equipment nearby in case of respiratory obstruction. And we also administer oxygen as ordered based on oxygen sat levels. So we want to make sure we have calcium gluconate ready, available at the patient's bedside if tetany develops. So this is if you have severely low calcium, you can actually develop tetanus or tetany, you have the first signs of it is tingling of the lips, numbness in the fingers. So you can go in and ask your patients how they're feeling, if they have any odd sensations, and of course we're going to check their labs. We're going to provide surgical site care as ordered, perform dressing changes as appropriate, making sure they may have hemovacs or they may have JP drains present. So we're going to encourage the patient to use alternate forms of communication to prevent vocal cord edema when the patient speaks. Note the quality and tone of the voice, and that might change, and that might be possible laryngeal nerve damage. Ensure adequate pain management as described with analgesics, and provide adequate fluids. Administer IV fluid therapy during the immediate postoperative period, and gradually introduce oral fluids. Make sure the fluids are cold initially, and then you can advance the diet as tolerated. Encourage well-balanced diet with adequate calories to maintain weight or promote weight. Obtain specimens including your serum thyroid levels and your serum calcium levels as ordered.